Every minute, another older adult gets news that changes a family forever. By the time this video ends, more people will be told they have dementia, and some of them will never hear the part that matters most, that the decline may not have started with age at all. It may have started with a medication they were told was routine, common, and safe. I'm Dr. Michael Carter, and after years of caring for older adults, I can tell you this is one of the most missed patterns in medicine. A person who has always been sharp starts forgetting names, missing appointments, losing the thread in the middle of a sentence, getting turned around on a drive they have made for years. Everyone around them says the same thing, it's just aging. Sometimes it is not aging. Sometimes it is the medicine cabinet. Today, I'm walking you through 9 popular medications that can speed up memory decline, cloud thinking, and in some people push the brain toward what looks like rapid dementia. We're counting down from the ones people overlook the most to the one I worry about the most in older adults. None of these are being singled out because they are bad medications in every situation. They are being singled out because in the aging brain, they carry a weight that most people, and honestly a lot of prescribers, underestimate. And watch for number 3, because it is still handed out every day for sleep, pain, and headaches, and many people taking it have no idea it can hit memory this hard. Before we start, tell me in the comments how old you are and how many medications you take every day. I read those comments and they shape what I cover next. Let's start at number 9. Number 9 is meclizine. You know it as Antivert, Bonine, and some motion sickness and dizziness medications people keep around just in case. It gets used for vertigo, travel, nausea, and that spinning feeling that can make a person miserable. And because it is so familiar, almost nobody thinks of it as a brain drug. But that is exactly what it becomes once you swallow it. Meclizine has anticholinergic effects. That means it interferes with acetylcholine, one of the key chemical messengers your brain uses for attention, memory formation, and mental sharpness. Younger brains can often absorb that hit and bounce back within a few hours. Older brains do not do that nearly as well. Part of the reason is biological. As we age, the brain naturally produces less acetylcholine. The blood-brain barrier becomes slightly more permeable, and the liver and kidneys clear medications more slowly. That means the same pill that makes a 35-year-old drowsy for an afternoon can make a 75-year-old confused, foggy, and forgetful for days. What makes this one dangerous is how innocent it looks. A person takes it for dizziness. The dizziness improves, but over time they feel slower, less clear, harder to follow a conversation, harder to hold on to a thought. And because the medication was started for something physical, nobody thinks to blame it for something cognitive. I have sat across from families who spent months worried about early dementia, only to find out the real culprit was a dizziness pill being taken 3 or 4 times a week that nobody had mentioned during the medication review, because in their mind it wasn't a real medicine, it was just something from the pharmacy shelf. If you are taking meclizine often, especially several times a week, that is worth bringing up with your doctor. Sometimes the real solution is not more medication. It is treating the cause of the dizziness, doing vestibular therapy, checking blood pressure changes when standing, or using the lowest dose for the shortest possible time rather than turning it into a daily habit. Number 8 is diphenhydramine. This is Benadryl. It is also hiding inside a shocking number of nighttime products: allergy pills, cold medicines, PM pain relievers, sleep aids. People take it because it seems gentle. It is over the counter. It has been around for decades. It feels familiar, almost old-fashioned in a comforting way. But inside the brain, diphenhydramine is one of the classic memory-dulling medications, and it shows up again and again in the medical literature on drugs that raise dementia risk in older adults. It is strongly anticholinergic, among the strongest of the commonly used over-the-counter drugs. In plain English, it blocks one of the very signals the brain depends on to stay alert and lay down new memories. That is why people often feel groggy the next morning after taking it, an effect doctors sometimes call the hangover effect. But the bigger issue is not one bad night. It is repeated use, night after night, month after month. I have seen people take a little something to sleep for months or years and slowly lose their edge without ever realizing the nightly pill could be part of the story. They blame stress, they blame age, they blame poor sleep, all while the medicine beside the bed keeps quietly adding pressure to the brain, night after night, in a way that never gets connected to the daytime forgetfulness they are experiencing. And here is the trap. People think, if it is sold without a prescription, it must be mild. That logic gets a lot of older adults in trouble, because availability at the pharmacy checkout line has nothing to do with how a drug behaves in an aging brain. If you use diphenhydramine for allergies, ask about newer options that are less likely to affect the brain, such as second-generation antihistamines that were specifically designed to avoid crossing into brain tissue the way older ones do. If you use it for sleep, do not assume sleepiness means safety. Those are two very different things, and confusing them is one of the most common mistakes I see in older patients. Number 7 is doxylamine. This is the ingredient in Unisom and in some nighttime cold and flu products. And in many homes, this is not even thought of as a medication. It is thought of as a sleep shortcut, something you reach for the way you'd reach for a cup of tea. That is what makes it so dangerous. Doxylamine knocks people out, and for someone desperate for sleep, that can feel like a miracle. But just because a pill makes you unconscious does not mean it is giving your brain healthy sleep. Natural sleep moves through stages, including the deep and REM stages where memory consolidation actually happens. In many older adults, doxylamine is giving you sedation instead of that natural architecture, along with morning fog, slower reaction time, poorer memory, and an anticholinergic burden that can build night after night, the same way sediment builds at the bottom of a glass. This one especially worries me because people take it casually. They do not tell their doctor, they do not count it as a real medication when asked to list what they take. Then they show up months later saying they cannot focus, they feel off, and they are scared their mind is slipping, and it takes real digging in the history to even uncover that they've been taking a nightly sleep aid the whole time. If a sleep aid is something you need every night, that is not a casual habit anymore. That is a real medication exposure, and it deserves a real conversation with your doctor. There are better long-term approaches to sleep than taking an anticholinergic hammer to the brain every evening, including cognitive behavioral therapy for insomnia, which has strong evidence behind it and carries none of this cognitive cost. Number 6 is hydroxyzine. Hydroxyzine is sold as Atarax and Vistaril. It gets prescribed for anxiety, itching, and sometimes sleep. Doctors often reach for it because it is not a controlled substance, so it can look like the safer option on paper, something that avoids the concerns people have about dependency with other anxiety medications. But safer for one problem does not always mean safer for the brain. Hydroxyzine is another medication with strong anticholinergic activity, comparable in some ways to diphenhydramine. In older adults, that can mean sedation, slower thinking, worse recall, more confusion, and a much heavier medication burden when it is combined with other drugs doing the exact same thing to the same acetylcholine system. This is where families get blindsided. A person starts hydroxyzine for anxiety or itching, then maybe they are already taking a nighttime allergy pill. Maybe something for bladder urgency too. Suddenly nobody is dealing with one risky drug. They are stacking several, each one adding its own anticholinergic weight on top of the others. And once that stack gets high enough, the brain starts paying for it in ways that can look shockingly like dementia, sometimes appearing within weeks rather than years. If hydroxyzine is on your list, especially if it is there for sleep or anxiety, ask whether there is a lower risk option that does not carry the same cognitive weight. Sometimes a completely different class of medication or a non-drug approach can manage the same symptom without the fog. Number 5 is the benzodiazepines. These are medications like Xanax, Ativan, Valium, and Klonopin. They are given for anxiety, panic, and insomnia, and sometimes they feel like immediate relief. The body calms down. The panic eases. Sleep finally comes. For someone in the middle of a genuine crisis, that relief can feel life-saving, but in older adults, the price can be steep. Now I want to be precise here. The research on whether benzodiazepines directly cause dementia long-term is mixed, and I don't want to overstate a link that the science hasn't fully settled. But what is not mixed is what these drugs can do right now to an aging brain. They can impair memory, they can slow reaction time, they can cause confusion, delirium, falls, and a kind of mental flattening that families notice very quickly, sometimes within days of starting or increasing a dose. That is why older adult prescribing guidelines, including the Beers criteria that geriatricians use, keep warning about them and recommend avoiding them when possible in older patients. I have had families tell me, he just hasn't been himself since that anxiety pill started. Less sharp, less engaged, more forgetful, harder to wake, harder to follow a conversation, even a simple one. That matters, even before anyone starts arguing over the word dementia, because it is affecting quality of life right now. And the cruel part is this. The longer a person uses them, the harder they can be to stop, because the body adapts and dependence can build even at prescribed doses. So never stop one suddenly on your own, since that can trigger serious withdrawal, including seizures in some cases. But never dismiss them as harmless either, just because they were prescribed for sleep or nerves, and just because they came from a doctor's pad. Quick pause for 1 second. If this is helping you connect dots for someone in your life, tap like and tell me in the comments how many prescriptions you take every day. I read those and it helps me know what this audience needs most. Now back to the countdown. Number 4 is cyclobenzaprine. That is Flexeril, one of the most commonly prescribed muscle relaxers in the country. People get it for back pain, neck spasms, or that tight, miserable, locked-up feeling after an injury or a bad night of sleeping wrong. And because it is called a muscle relaxer, people imagine it works mainly in the muscles, the same way a topical cream might. It doesn't. Cyclobenzaprine is structurally very close to older tricyclic antidepressants, and it carries anticholinergic effects that can be rough on older adults. That means drowsiness, slower thinking, dry mouth, constipation, poor balance, and yes, more confusion and memory problems than many people expect from something marketed simply as a pain medication. This is another one that sneaks up on people because the prescription often starts with a real physical problem: a strained back, a pulled muscle, a week of bad pain after yard work or a fall. But the medication lingers longer than planned, gets refilled without a second thought, and slowly turns into brain fog that nobody saw coming because everyone was focused on the back, not the mind. If you are over 65, a muscle relaxer is not automatically a simple, low-risk drug. It can be one more hit against clarity, and it can also raise fall risk through sedation and dizziness, which creates its own separate danger. If you are already taking sleep aids, allergy drugs, or bladder medications, the burden climbs even faster, and the combined effect can be far greater than any one of those drugs alone would produce. Number 3 is amitriptyline. This is the one I told you to watch for. Amitriptyline, also known as Elavil, is still used for nerve pain, sleep, chronic headaches, migraines, and sometimes depression. And that is exactly why it spreads so quietly. It sounds useful, versatile, almost clever. One pill that can help several problems at once, which makes it tempting for both patients and prescribers looking for a simple solution to a complicated set of symptoms. But in older adults, that convenience can come at a brutal cognitive cost. Amitriptyline is one of the heavier anticholinergic medications still commonly used today, decades after it was first introduced. It does not just make some people sleepy. It can interfere with attention, processing speed, word finding, and memory itself, hitting several cognitive domains at once rather than just one. And because many people take it at night for sleep or nerve pain, they do not always connect the next day fog with the pill they took the evening before, especially if the fog builds so gradually that it starts to feel normal. Then weeks turn into months, and the prescription just keeps getting refilled because it seems to be helping the original problem. And slowly the complaints start sounding frighteningly familiar. I can't remember names. I lose my train of thought. I walk into a room and forget why I'm there. I feel like my brain is not as sharp as it used to be. Family members start finishing sentences for their parent. Appointments get missed. Bills go unpaid, not because the person doesn't care, but because the follow-through required to manage them has quietly eroded. That is why this one worries me so much. It is often prescribed for problems that sound harmless compared with dementia: trouble sleeping, nerve pain, headaches, but the medication burden it creates is anything but harmless in the wrong patient, particularly someone already older, already frail, or already on other medications from this list. If amitriptyline is on your list, especially after 60, ask whether there is a lower risk option for the reason you are taking it. Many times there is, whether that means a different medication class entirely or a non-drug approach for the underlying problem. Number 2 is paroxetine. That is Paxil. Paroxetine belongs to the Shri family, and because SSRIs are often thought of as the modern, safer antidepressants compared to older drugs like amitriptyline, many people assume all of them are basically interchangeable. They are not, and this is one of the most important nuances in this entire list. Paroxetine stands out because compared with many of its SRI cousins, it has meaningful anticholinergic activity, more than would typically be expected from a drug in this category. And that matters, especially in an older adult already taking other medications that hit memory and alertness from different directions, since the effects can compound rather than simply add up. So a person starts Paxil for anxiety or depression and thinks they are taking the gentler option, the modern choice their doctor reassured them about. But over time, they feel less clear, less focused, less sharp. Their mood may improve while their thinking slowly gets duller, and because the mood improvement feels like success, the cognitive cost can go unnoticed or get dismissed as an unrelated issue. That is a trade-off many people were never told to watch for, and it is one that deserves far more attention than it usually gets. This one is especially frustrating because there are often alternatives in the same general category that are considered easier on cognition in older adults, meaning a person doesn't have to choose between mental health and mental clarity. But if nobody brings it up, the prescription just keeps rolling forward year after year, refill after refill, without anyone stopping to ask whether it is still the right fit. If you or someone you love is on paroxetine and there has been a noticeable decline in memory or clarity, that deserves a serious medication review. Not panic. Not quitting on your own, since stopping an antidepressant abruptly can cause its own withdrawal symptoms, but a real review with a doctor who understands both the mental health side and the cognitive side of the equation. And number 1 is oxybutynin. This is ditropan, and for me it is one of the most concerning medications on this entire list when it comes to the aging brain. Oxybutynin is prescribed constantly for overactive bladder and urinary urgency, a problem that is incredibly common in older adults and one that genuinely affects quality of life, dignity, sleep, and independence. Because the need feels so real and so personal, people rarely question the medication once it starts working. It stops the frequent trips to the bathroom, it reduces the accidents, it lets someone leave the house without worrying. On the surface, it looks like a clear win. But oxybutynin sits near the very top of the anticholinergic scale that geriatricians use to measure how heavily a drug loads onto that same acetylcholine system I mentioned back at meclizine. This is not a mild anticholinergic like some of the others on this list. It is one of the strongest ones still in routine use, and it is often taken every single day, sometimes for years, without a single conversation about what it might be doing above the neck, rather than just below the waist. Multiple large studies looking at long-term anticholinergic exposure and dementia risk have flagged bladder medications like oxybutynin specifically because the daily, ongoing nature of the treatment means the cumulative exposure adds up in a way that occasional use of something like meclizine simply does not. Add in the fact that this population is often already older, already on other medications, and already vulnerable to cognitive decline, and you have a recipe that concerns me more than almost anything else I regularly see prescribed. The tragedy is that the bladder symptom and the cognitive symptom get treated as two completely separate problems by two completely separate parts of the healthcare system. A urologist manages the bladder, a family worries about the memory, nobody connects the daily pill bridging both. If oxybutynin is on your list or a parent's list, this is worth a direct conversation with a doctor. There are newer overactive bladder medications that work through entirely different pathways and do not carry the same anticholinergic burden, along with non-drug approaches like bladder training and pelvic floor therapy that can reduce or even eliminate the need for medication altogether in some people. What I want you to do with this list, I did not make this video to scare you, and I am not telling anyone to stop a medication on their own after watching this. That can be dangerous. And some of these drugs, especially the benzodiazepines and certain antidepressants, need to be tapered carefully under medical supervision rather than stopped abruptly. What I am telling you is this. If someone in your life has had a noticeable change in memory or thinking, do not stop at the word dementia. Ask for a full medication review, sometimes called a brown bag review, where every single pill, including the over-the-counter ones nobody thinks to mention, gets laid out on a table and looked at together. Ask specifically about anticholinergic burden, a term more doctors are starting to take seriously, but one that still gets missed in a rushed 15-minute appointment. Bring a list, bring the bottles themselves if you have to, and ask the direct question, could any of these be contributing to what we're seeing, rather than assuming the answer is simply age. Sometimes the answer really is dementia, and that deserves compassion, honesty, and a real plan. But sometimes, more often than people realize, the answer is sitting quietly in a medicine cabinet, disguised as something routine, something common, something safe. And catching that difference can change the entire trajectory of someone's life. If this video helped you, or helped you think differently about a parent, a spouse, or even yourself, share it with someone who needs to see it. Tell me in the comments which of these 9 surprised you the most, and let me know if you'd like a follow-up video on safer alternatives for each one of these conditions. I read every comment, and they genuinely shape what I cover next. Take care of that brain. It is the only one you get.